All right, thank you for your patience.
Okay. Oh, you're very welcome. Okay.
Okay, Carrie, so we're going to go ahead and get started. We'll introduce ourselves in just a moment again. So
Okay.
before the session starts, we'd like you to do our pre-session evaluation. You can go ahead and do a QR code with your phone, or if you can't access your phone, we can put a link in the chat box.
Link would be great. Sometimes for the reason I have a Galaxy, it won't always take it. You go to the restaurants now, you try to scan it, but mine doesn't pull up anything.
Okay,
So that helps that it's in the chat. Thank you for
thanks.
that.
Yep, so we'll give you about 3 to 5 minutes. Just let us know when you're finished.
Okay, let's see. Okay. Okay, let's see. All right, I completed it. I
Awesome
hope I did a good job.
job. It's all anonymous.
Okay.
And I won't even, anyway, I'm going to trim the video to start, and next time, Maya, let's start after this part. I just realized we are just rookies. Okay. So Carrie, I'm Carolyn Custer. I was with the authority for several years and the director of community medicine, and I did a ton of public health projects and stuff. So that's why I'm here.
Okay, thank you.
Yeah.
And my name is Maya Campbell. I am a community health worker. I'm also with Mishwa. I am the database and registration specialist. I've had the absolute pleasure of working in the city of Detroit and also throughout Wayne County, doing different case management for different organizations. So I'm so happy to meet you and be one of your facilitators today, Carrie.
Okay, great. And so I've been with the Mario and Associates for about a little over a year now. So it's a sort of a career change, but so what I found that my niche is probably on the community outreach side, connecting partnerships, reporting, doing extensive research on, what it is that any disparities that the communities are facing, and depending on what that is. So, we do a lot with city and state government. So I'm excited to always learn something new, and actually it raises questions, some of the good work and that you're doing, in ways that we can continue to engage the community, and let residents, especially in the Metro Detroit area, know just how critical it is to they have to date on your vaccines, and look at your health issues and how it affects the community and why it's so important, especially coming out of I don't know if we're really in the pandemic or not, coming out of the pandemic, and so much has been highlighted. So it's very, important. So I'm glad that you're doing this and you're on the case.
Thank you. We appreciate that.
Mm-hmm.
All right, so we're going to do an overview of health literacy, of course. We'll talk about 5 interventions that we can employ to increase health literacy, and we'll take a quick break, and then we'll come back and talk specifically about the COVID vaccine and some strategies specific to that. If we have time, we'll do a case discussion at the end.
Okay.
The learning objectives are to describe health literacy as a determinant of health. And then really we're going to talk about class, culturally and linguistically appropriate services, and reflect on strategies for culturally competent care. And then the other part, of course, is to understand causes of vaccine hesitancy and identify strategies to mitigate that. So we start with a brief review of health equity. It's impossible to talk about health literacy without talking about health equity. So have you seen this before, Carrie? This picture?
No, I have not.
Okay, so actually this is the traditional approach of how we've talked about health equity, equality being everyone gets the same, equity being everyone gets what they need to succeed. But we're going to push it a little bit forward from that, and we're going to go on to the concept of justice, which is removing the inequity in the first place. So, we're talking to CHWs, we're talking to people like you and me, we're talking to a lot of people who are social justice warriors, right, by heart. So we want to frame everything in how we move forward, and moving forward is the concept of justice. And just one quick other thing that I'll review, and are you familiar with social determinants of health?
Yes, I am.
Yeah. So we know that where you're born, the place that you live, can dictate your health overall, right? So access to all of these different things impact health. And, what we do in the clinic or clinical care is like 20% actually that contributes to the whole. All these other factors are what can, make a person healthy, whether or not they can get to the doctor, whether or not they have money to pick up their prescription, education opportunities. So there's a lot of things, like we talked about the last slide with, social justice, these systems that have been built. I always tell my undergrads when I'm teaching, you guys have to do it. It's up to you now. Break these systems down. So that's the lens that we're going to look at, and Maya's going to take it a little further.
Thank you so much. So the next few slides, we're going to talk about health disparities and structural racism. The CDC defines health disparities as preventable differences in the burden of disease, injury, violence, or opportunities to achieve optimal health that are experienced by socially disadvantaged populations. They exist because health inequities and factors like social determinants of health and systems that are designed with structural racism. Go to the next slide. So, and we can open this for a little bit of discussion since we have a small group today. Health literacy in Wayne County. Of course, we know, well, let me just ask this for you, Carrie. What is health literacy to you?
Probably, first of all, understanding, what that means, what it means, what healthcare means, what it means to what your everyday life looks like. Are you eating healthy? Are you, you know, um, being an educator, looking at the food chart, putting all those basic, food, in your daily diet. But I guess also it would be just knowing where to probably get health care. Are there clinics and hospitals in an area where you live? I know being a Detroiter myself, I know just in my lifetime, hospitals have closed in the city. And depending on where you live on what side of town determines how close you are to one. So, probably part of that. And all the more reason some of my high school friends who are teaching, some of the high schools have clinics in the schools because so that the kids can, just on a side note, can have access to their what's it called? When they get their physicals and things. I mean, it just was a barrier. Kids couldn't get physicals. Their parents weren't taking them to get, so they put clinics, or they would have the traveling doctor come to the school. So just, I've seen over the years removing those types of barriers. I guess that's what it would mean to me, that help.
Great, great. Thank you so much for sharing that. I'm sorry to put you on the spot, Carrie.
That's okay to think about. It's okay.
Lots of good stuff.
Yes, very, very good stuff. So if we check this slide out, that's exactly what this slide is talking about. Some of the redlining, this is a map of Wayne County. And if we see where the redlining is, it's where within our city of Detroit. So like you mentioned, Carrie, the access to hospitals and healthcare, and the access to education. So we know historically about the redlining in Detroit and in Wayne County, more concentrated in our cities or our communities of color. We can go on to the next slide. So that's exactly what we just mentioned. What is health disparity? Health literacy. Do you want to talk about Healthy People 2030?
Sure. Traditionally, we've every 10 years, Healthy People comes out, and they've had health literacy as a goal for the last few decades. Traditionally, though, the onus was really on the person, the patient, right? So the patient has to, we use the term personal health literacy. Go ahead, Maya.
Oh, I'm
I don't know
sorry.
how you want to do that. I feel like I need to do this slide now.
It's a team effort. So personal health literacy, there's a definition there, the degree to which individuals have the ability to find and understand and use the information and services. So does the patient have the ability to access or really digest the information that's given to them in the clinic? We can go to the next bullet point.
So this is what I was going with. They added organizational health literacy because we realize it's not just on the patient or the person using the service, it's on us as the providers to also promote health literacy. So go ahead.
Yes, that's exactly true. So I think that's the last point on this slide.
Okay.
So health literacy components, the skills and knowledge needed to interpret health information. Literacy, of course, means reading, writing, basic math, speech, and comprehension skills. I always butcher this word, numeracy. I'm not a math person. Numeracy, understanding how math is used in the real world and being able to apply it and make the best possible decisions. Factors that impact health literacy, these are big ones. The complexity of the health information, language, age, state of the health. Is the person anxious, or are they, when they come into the clinic, are they suffering from some illness, and cultural background? The way the health information is communicated. So is the provider clear? Are they using medical terminology that the patient may not understand? So on and so forth. Next slide. So this is just a chart of the exactly what we talked about. So the individual health factors, literacy skills, the health knowledge, demographics, culture experience, and then the system or the professional factors, the public health practice. public health infrastructure, and public health workforce. All these components make up health literacy.
Okay, so just briefly, some of the impacts of limited health literacy, we talked about health. People with lower health literacy are less likely to use preventive care services. And this is exactly what we were just talking about with the school-based health centers and the wellness checks and the vaccines and whatnot. So missed opportunity for that, less likely to effectively manage chronic disease. If you're not sure about how to take your meds or what things mean, then it's hard to stay compliant with that, right? So we do see that. More likely to have poor medication adherence, higher rates of hospitalization and use of ER, less use of primary care as the first step, and then higher mortality rates, unfortunately. Reporting a sense of shame, people that have literacy problems can have guilt and shame feelings about that, and that can cause a feedback loop where they don't want to ask questions because they would, admit that. So there is that sense of shame that we have to think about. And of course, all of these are associated with a higher healthcare cost and expenditures. So this is something we need to work on. Impacts of community health literacy. So these are the things that you guys work on probably a little bit. Opportunities like we do the community outreach, vaccine, preventive screenings and whatnot. Lack of preparation for emergencies and disasters. These are just some other impacts on a community level, things like environmental safety, food warnings, of course, food safety. So those are some of the things that can result if our community is not health literate or has a lower health literacy. So just to tie it with literacy, the average reading level of adults is 8th to 9th grade. Unfortunately, most of the health education materials that we see are created at the 10th grade level or higher. Fortunately, though, we've really, worked on what reading level our materials are at and how it's presented. So the recommendation really is to create materials with a reading level of 5th to 6th grade. And that way you are ensuring that there's comprehension for most people, the majority. Some red flags for low literacy, when you see a patient or you're interacting with a patient or consumer, you might see some of these things. Incomplete registration forms, unable to give history, asking fewer questions. That's another thing, the person who's at the doctor and they just nod, right? And they're not asking any questions. That could be a red flag, right? So these are just some of the things to become familiar with. Any questions on any of that, Carrie?
No, it just made me think about when I used to teach, I used to, tell the kids, I don't know if it's still in place, the free press, Detroit Free Press is written on a 5th grade level, and then the New York Times at a 9th grade level. And so, of course, kids will go back and forth, but if you really think about like the testing, the benchmarks that we do with testing in the schools, whether you go as far as, what's the NEAT, but even when you do the SAT and ACT, that's about right. So you're expecting the kids to be at a certain level. And so I'm just got right. You said, I'm surprised that so the most health education is 9th grade level, huh? Well, I do keep a thesaurus at my desk to this day still. Every now and then you come across a word you don't understand. I believe in asking questions, but there is a lot of hesitancy. People don't always ask questions. They just assume that the doctor's going to tell them. But you're not going to retain that either, especially the information comes at us so fast. So you're not going to retain that either. So yeah, I could see people skipping over, those boxes.
Yeah. Okay. So we're going to talk about using a universal precautions approach. This originated with bloodborne pathogens in medicine. We couldn't tell who had HIV. You can't tell who has HIV by looking at them, right? So anytime there's a blood exposure, you assume it's positive for not only HIV, but hepatitis, etc. So for health literacy, again, you cannot tell what a person's health literacy level is just by looking at them, where they work, even their education level, right? So we say, okay, let's just assume everyone has low health literacy. That's the universal precautions approach. And it just changes the way you communicate, The goals, of course, are to simplify communication, confirm comprehension, making the healthcare system easier to navigate, and supporting our patients' efforts to take control of their own health. So the more we normalize, the less we stigmatize. This slide just shows what a health literate organization would look like. And I don't need to go through all the individual points, but it does outline that there are, health literacy has to be a priority all the way from the top. It needs to be baked into all the systems to really be a health literate organization. Staff training, accessibility to patients and consumers, etc. So lots of things that go into that. Maya, I'll turn it to you.
Okay. So I just wanted to briefly share a story about low health literacy. I actually have a different story from before. This actually happened while working in a clinic in the city of Detroit. I had a patient that came in. English was not her first language. So she struggled through the appointments. She would often bring her son into the appointments to help her to translate. But she was having some things going on with her uterus, and she was doing some screenings for some different cancers. So it was very embarrassing to her. So during the appointments, she said very little. She would nod, and when the provider would say, "Do you understand?" she would say, "Yes, yes, yes." But then later she would call the reception desk, and she would have all these questions. What are these medications for? I didn't really understand. And then her son would often call and say, "My mom is very confused about her next appointment, what was said." And I built a rapport as a community health worker with this patient because it was very obvious that she had low health literacy of no fault of her own. Of course, there was a language barrier, and she was doing what she thought was best by bringing her son to help translate, but also the information was very confusing for her son as well. So I think it's important to recognize those things when we're working with the community, that even when they have their supports around them, but if the supports also have low health literacy, her son was able to translate, but it was difficult for him to translate medical terminology that he didn't even understand. Mm-hmm. So Carrie, do you have any experience with patients or even a family member that has had issues with health literacy?
Sort of. My mother-in-law had breast cancer, and she didn't always understand what the doctor was saying. So it got to the point where she gave permission to my husband and I to sit into the doctor's appointments, and so that we were all hearing the same thing. And so what she thought she did or didn't, we clarified for her. So then she kind of had a better understanding because she was already nervous and anxious about it. But yeah, so we would go to her doctor's appointments with her through that journey. I mean, she's been cancer free now for 6 years, but going through it, yeah, she I don't know what she would have done if probably had we not sat there with her. And she didn't understand, even with like the medications, why she's so hesitant about anything where you have to take something foreign in your body. But and we understood, explain to her, this is gonna help you get through this, especially after chemo and all that. Yeah. So because she didn't understand, everything that was going on.
Great. Thank you so much for sharing that, Carrie. I can definitely relate to that. My mom is a breast cancer survivor.
Okay.
And I that cancer, when we hear certain words, even us as a family, it's like, that's scary, cancer, chemo, treatment, surgery.
Mm-hmm.
So they kind of get an autopilot, but that's definitely one of the points, the anxiety that patients have around going to the doctor does definitely impact their health literacy. So thank you so much for sharing that.
You're welcome. Mm-hmm.
And my thought was, there is the role for the CHW, right? We just need to get it going. I mean, how awesome would it be? I mean, you have attended appointments, right, Maya, with patients before?
Yes.
Oh, wow. Yeah.
Yeah.
Mm-hmm.
Okay.
All right. I'm sorry.
I just said okay.
Okay. So health literacy interventions, that's the next few slides we're going to talk about. So these are some strategies that increase health literacy within patients and create health literate environments. So the first strategy, I absolutely love this, is clear communication. So are we greeting patients when they come in? I always like to relate going to the doctor's office with shopping, because it can be a great experience or it can be an anxiety provoking experience. But the big thing, when we walk into that fancy boutique, we love to be greeted. Hello, how are you? How can I help you? Are you looking for anything in particular? So it's similar when we go to the doctor's office. Is the receptionist warm? You know, are they saying hello? Even if there's lots of people, are they making eye contact and listening carefully? It's important that we also use plain non-medical language. So try to steer away from medical terminology. Recite the patient's words. So listening and what words are they using, and recite those back when we're communicating. Slow down. I know this is a big one for me. So I know we talked about it sometimes when we're experienced in the field. We kind of go into autopilot and we get in our groove, and but sometimes just slowing down. So limit and repeat content, be specific and concrete, show graphics. So I am a visual learner. So any graphics, I always think about when I go to my OBGYN, those graphics of the birth control are very, very powerful because we know what they look like. So imagine trying to explain like an IUD or some other type of birth control device without the actual graphic there. It's difficult. So those graphics are very powerful. Demonstrate how something is done. A very important thing. I used to love to show our patients who were suffering from who had diabetes how to use the meters. That was very important. Invite patients to participate and encourage patients to ask questions. Next slide. Okay, so 7 things to consider when communicating. I'm going to go over the first 3, and then Dr. Custer will go over the last 4. I'm sorry, the last 4. So trust. Will the person trust you, or will they trust the information? Who is the best source to put out that information? Sometimes the best source is the community health worker. They may have more time than the doctor, and the community health worker may have built that rapport with the patient. The information, what information is necessary and how will people find it? How much is enough and how much is too much? So I know sometimes information overload is a real thing. So sometimes breaking the information down to what is relevant to that patient at that time. Motivation, how relevant is the information to the people we're trying to reach? That's another very important thing.
All right, I'll take it from there. Environment. So again, what are the conditions that surround and affect the audience? Are you communicating in a safe private area, or, is it in the middle of a loud area with a bunch of staff that can overhear? So making sure the environment's right. Capacity, you have to assess the capacity of the person you're talking to. And if there's any barriers to acting on what you're saying, work with the patient or person to build that capacity so they can take care of whatever it is. Perception, you want to present information or communicate in a way that the audience can think about it and in a way that will inspire them to act. And then response, you have to think about how will people respond? What can we do to keep them engaged? How can we give them support? So those are the things, the 7 important things. Plain language, using plain language is very, very important with health literacy. There's a lot of, medical terminology that doctors and we can just start talking and not have any idea that what we're saying doesn't make any sense. So again, the big one here that I always touch on is diet. Because if you ask someone what diet they're on, they usually, or what is their diet? A lot of times people think like Weight Watchers or, Atkins or whatever diet, when in actuality, we want to know what they're eating. So the better way to say it would be, what do you eat? Adversity, adverse is another one, you have an adverse outcome. Bad is a better word to use. Your COVID test is positive. So again, using plain language, I had a situation where we had a lot of COVID and we were testing, and someone thought that positive was a good thing because positive is a good thing. So at that point, we started saying you have COVID or you do not have COVID, just to simplify. You see what I'm saying?
Yeah, right. Okay, right.
So it does happen.
Mhm.
Okay, so that's pretty much communication. Any questions about that?
No, there isn't. That was really good about the bloodborne pathogen because for years I would do latchkey programs in the city of Detroit at several schools, and we would have to take the bloodborne pathogen, training and whatnot. And I would always tell my staff, you have to assume, because parents don't have to, because of integrity and confidentiality and all that, if their child has HIV, let alone any other disease, like the hepatitis or whatnot, and for that matter, parents or whatnot. So we would just handle anytime there was a nosebleed. I don't know what it was about the summertime. We would have these nosebleeds. The hot kids get hot and dehydrated, or just in general, if we were just attending to a first aid type situation where they fell on the playground with the gloves, and we had to assume, and without judgment, that the child may have something. And we had to dispose of course, any blood, that we would remove from the scene and properly.
Right.
So you're right about that.
Yep. So it is a good way to look at it.
Mm-hmm.
Okay, so now we're going to move on to looking at materials and talking about health materials. I think you do this a lot. But again, just a reminder that readability we aim for 5th to 6th grade. So for a health education to be effective, the materials, they need to be easy to read and understand. The purpose is clear. Try to limit irrelevant information. We're just looking for key messages on these effective materials. I think we've said this so much, we don't have to say this anymore, but avoiding medical terms, using common language, breaking material up into chunks that makes it easier to understand when you're looking at it.
Mm-hmm.
Material, something, it identifies at least one action item. That is a good thing. Using visual aids effectively is good. And then of course, be aware of confusing numbers. Statistics can confuse, especially relative risk when you're trying to say, okay, it went up 30%, but the baseline, it didn't go up 30%, went 30% up from the baseline. So, that can get a lot of confusion. So what we're going to do now, Carrie, is we'll go through some health education materials related to COVID, and we're going to ask you what you think. So the first 3 flyers are, this left one is MDHHS, the right is CDC, and the middle is Authority Health. These are all related to going back to school or having child vaccination, basically. And out of these 3, which one for you is the most effective, just looking at it? Or we can do it individually.
Probably the first one, the keeping the school year fun going.
Okay. And keep up to date with the booster. So the action item is go get a booster, right?
Yes.
Yeah.
Yes.
Yeah.
Mm-hmm.
This one, what do you think about this?
It's probably a lot to read, and actually the first thing I thought was it reminded me of the Gleaners Community Food Bank flyer. I've done a lot of work with Gleaners, but it's great. It's just, and the little girl's cute, but it's a lot more to read.
Right.
And it does say, small at the bottom of the vaccine, I don't know if that's eye-catching if you want the parents or, to see that, but it's a lot more to read.
Right. And then this one, what about this message? Keep your cubs safe.
I do like that one. I like that one. I guess what got me is the youth in the first poster, but I do like the middle one as well.
And that's, and that's what we're, so looking at stuff that'll work. This is very clear.
It is. Keep your, yes, it is. It is.
Okay, so let's look at this next slide. This one came out, MDHHS came out with this right in the beginning when people were like, it's been way too fast. There's no way a vaccine could be developed that fast. Do you think this is effective for people that we serve? Research, clinical development, diverse scientists, doctors. Would this change anyone's mind that you work with?
No, it would not. No.
And that's pretty much consistent across, and they even translated this one into all, and what is this picture, right? So this was just not a good message, in my opinion.
Right.
So the next three, I have a couple that are overlaid that we're going to look at. These are all MDHHS. The first two are about, we want to talk about clear messaging. Anytime you have multiple asterisks in a message, it's not that clear anymore, right?
Okay.
So I'm just trying to show
see.
you that. Here's another one. This one caused a lot of confusion. At least in my world, people were calling me all the time, my daughter's still sick on day 6, but her boss wants her to come back, and I don't know what to do. And so again, you have multiple asterisks. It's not clear. This one, make a COVID plan. What do you think about the big points versus the small font?
I think the font should be larger, but also if there's a lot of reading. And it could be confusing. I mean, and it goes back to me, my daughter, who's a freshman in college right now, but when we were hit with the pandemic, I want to say her junior year, she had to stay home. She sat next to somebody with COVID who tested positive. Then it got to the point where, just watch her. Then it was no, she used to be home for 8 to 10 days. I mean, I should say that she was a junior in 2020, but in 2021, when they came back to school in person, I felt like every other month she was home for 8 to 10 days.
Wow.
So I feel like her last year in high school, she was just virtual learning. And I try to understand the chart. The principal would email us the chart, what to do, who in her quadrant, who she was near. They traveled with 10 kids in the school.
Wow.
I'm like, so can she come home? Is she okay? We took the negative test. We were constantly. So yeah, could be confusing. Yeah, even as a parent. And I would ask, okay. And then they would talk about this, what the CDC said. Then they have an emergency parent meeting. Sometimes the superintendent would show up. I'm like, okay, but if I'm confused and I try to read everything, I know it has to be other parents. And we're in Sterling Heights, and it's very diverse, and there's a lot of language barriers. It's very culturally rich community. I'm like, I know if I don't understand, everyone can understand in this room or on this virtual call. So
yes.
You're absolutely right.
Yes. So, just all they need is the big points. They could totally get rid of the small font and we would be okay. Except for the word therapeutics. That's not going to work, but medication.
You can Google everything. How do you feel about it? Because I mean, I guess everyone can Google. So everyone Googles all of this, and a lot of things flew on social media about what is right and what isn't. I don't know if people were listening to other influencers and not the CDC and the NDHHS.
A lot of
they could Google everything.
Right. We'll talk about that a little lot.
Okay.
For sure. All right, Maya.
Okay, thank you. I love the discussion. That last slide was very powerful, so thank you. So let me just put it up on my end. So how do we feel about this MDHHS flyer? Just right off, if we think about the population that we serve, Carrie, so I'm going into, let's say, a health department, and I'm a parent. How do you feel about this slide? Just your first impression.
I mean, you may be a little hesitant. I don't know if it's a little, how can I say, depressing maybe? Like, are you like, there's got the sick child, she's looking at is it the temperature high? You're looking at the thermometer, and then now the child's in the bed sick and you're holding the hand as a result. I mean, it might force me to hurry up and get that, COVID, vaccine, and then make sure I stay up to date on my boosters, but it's a little downing. To me.
Yes.
That's something we haven't heard, but that's true. Think about
it's very true.
It really
it's like sad. But look, the last box, if you get your vaccine, you're not sad.
Right.
Yeah.
Right.
Okay.
One little girl's crying because it doesn't hurt. I mean, some kids have their own anxiety. Look at the kids who are just anxious about even going to the doctor.
Yes.
She's crying, I guess, after her shot. I don't know. To the right.
No, she has ongoing health issues. That's what it says.
So that is a very, I love that. So I love that, the feelings that this provoked. Yeah, and it is a little triggering. We see the baby crying and the person in a hospital bed with an IV. So it's a little bit of scare tactics.
Mhm.
There's some great information, don't get me wrong. I think there's some amazing
Yeah,
information
there
on
is.
this flyer,
Mhm.
but it's also a lot of information. And if we recall what we learned earlier, the education level of most adults, this may be a little bit of an overload. And
Okay.
like we talked about,
Mhm.
information overload is real. So I'd probably get through the first few bullet points and then my brain would start to, yeah. So thank you for sharing that. Can we go to the next slide?
Mhm. Oh, I apologize.
Okay, so how do we feel about this slide? This is from the CDC.
It can be effective if you read through all the information. They're actually, I can see they're promoting the mask wearing, which is very highly effective at mitigating against the spread. I get that. And with the second, there's quite a bit of reading.
Yeah.
I do see the bullet points for the symptoms and whatnot, what you should be looking for, after the side effects that you may experience once you get the shot. Let's see. Of course, there's other information from the CDC. Yeah, a lot to read. A
Yeah.
lot of read if you have an educational, some type of barrier, if you're, and especially if there's that, you're illiterate, and we know the literacy rate in Wayne County is a little low. I was rather it's
Sure.
high. Was it 47 or 50% or something? Adults are illiterate. That's pretty high.
Mhm.
Yeah. So the last two slides, this one and the last slide, have this the exact same information.
Wow. Oh my God.
Right. So although the MDHHS flyer was a little bit scary for us with the baby crying and the IV,
Yeah.
I think it's a little bit more eye-catching, but definitely
Mhm.
I love Carrie. You're so amazing. Like the different perspective that we hear, even just from the graphics at the top of the CDC flyer with the children wearing masks. So
Right.
I love, but it is both of them are a lot of information. So we have to disseminate that. Our patients or our population served. This may be a little bit off-putting. It's great information, but just based on what we learned, it could be overload.
Yes.
Thank you.
Oh,
So, I'm sorry. Go ahead. Oh, we're all
okay,
good. Yep.
okay.
So using health materials, just to sum it up, don't assume that your patients can read. You brought up a great point. Depending on what population we're serving, there may be literacy issues. When reviewing a handout, it's important because just as a community health worker and also as a community organizer, fortunately but unfortunately, the materials that we have are the materials that we have. We can't always break it down and make it suitable for everyone. So circling what's important, prioritizing materials by adding patient names and medications, and using teachback. So we'll discuss teachback a little bit more. And emphasize the importance of keeping materials. I know this is a big one because not everyone's going to keep everything, but giving patients, even a health journal, if that's useful, having them bring that back to other appointments, and make sure patients have internet access when recommending digital materials. It's so very simple. And I know you use the example about your daughter's school, the guidelines changing a lot. So it's easy to say, if you have questions, check the CDC guidelines or check the MDHH website. But what if I don't have access to the internet or I don't have a smartphone? So what may be our norm, smartphones, laptops, tablets, that may not be the norm for everyone. So thank you so much.
Thank you, Maya.
Mhm.
Oh, obtain patient feedback. Sorry, that was
Oh,
my.
I'm sorry. I'm saying the feedback. So ask them, this is great with Teachback, asking them, do you understand, or ask them to recite what they heard and also getting their feelings about it. So just exactly what we did, showing them the material and ask them, how do you feel about this? So that feedback is very important.
Okay, Carrie, we're going to move on to our third strategy, health literacy strategy, and that's the teach back method. Have you heard of teach back before?
I don't think so. No, not the teach back method. I
Yeah,
was gonna ask what that is.
you do teach back your whole life, probably.
Probably.
So we know, like you mentioned, I think you said this before, 40 to 80% of the information patients are toward is forgotten immediately. And nearly half of it, the rest is incorrect. So there's definitely a need to improve how our patients comprehend and retain information. So teach back's a great way. So it's just a method that we teach. It's a way of checking understanding by asking patients to kind of just explain back in their own words what they need to do, what their action item is. It's not a test or quiz, right? We're not pimping patients, but we really put the onus on ourselves. We say, okay, I want to make sure I explain things clearly. And teach back can be very helpful for improving patient understanding, adherence to treatment plan, decreased callbacks and canceled appointments, which is good. And then of course, improved patient satisfaction and outcomes. So elements for teach back, communication, everything we talk about today all boils down to basically the same: empathy. Have empathy, use a caring tone of voice and attitude, displaying comfortable body language, making appropriate eye contact, of course, plain language and user-friendly materials. So we're going to ask the patient, after we've taught them something, to explain back using their own words. Open-ended questions are the best, not, so are you going to take this medication twice a day? Yes, no, we need to have open-ended. Tell me how you're going to take that. Avoid, and then emphasize, of course, like I said before, that the responsibility is on the provider, myself, not the patient. So just an overall schema of how it works. You go ahead and teach information. It is advised, if there's a lot of information that you have to go over, to chunk it up. So if they have, for example, they have to do something for their asthma and diabetes, you wouldn't talk about all of that at once, right? You'd chunk up asthma and then you'd go to diabetes. If the patient's able to retain and teach you back the most important information, then you've done your job. If there's still confusion or any underlying things, just go back and reteach using different words, or a demonstration, or potentially a different handout. However you have to accomplish this goal. So Maya and I are going to reenact a teach back. This is very, very short. If you're interested, Carrie, there's a ton of videos on YouTube about this with the actual methods. This particular strategy could be a whole course in itself. So let's go ahead and do this. So we're gonna do the next few slides. I'll be the healthcare provider, and Maya will be the consumer patient. And we're going to use the slides in lieu of an actual handout. So just bear with us. Okay. So Mrs. Campbell, as you know, your COPD and diabetes put you at a higher risk for developing severe COVID. I forgot to say that Miss Campbell was diagnosed with COVID in the office today.
Okay.
So I'm going to prescribe you the antiviral medication for COVID called Paxlovid. So this is what a dose of Paxlovid looks like. You can imagine I'm using a handout. There's 2 pink pills and 1 white pill in each packet. And these are the names of the medications for each pill. You have to take each packet, all 3 pills, 2 times a day for 5 days. So in the morning and at night. And then here I show this, here's some general instructions. So it's really important that you don't remove the medication from the blister pack until you're ready to take it. Make sure that you swallow the tablets whole and don't take 2 doses at once. If you forget to take a dose, if it's within 8 hours, you can retake it. If not, you just skip it. So I've highlighted the most important things here. And I wanted to show you this list. These are the medications and supplements that you need to avoid. Are you currently on any of these medications?
I take supplements.
Okay. Are you taking St. John's wort?
I am, yes.
Okay, so you'll want to make sure and avoid that while you're taking Paxlovid.
Okay.
And then one last thing, Paxlovid does have side effects. The most important, most serious that we want you to look out for is liver damage. Liver damage can make your eyes or your skin turn yellow, and it can also make your skin really itchy or your urine dark. And then there's these other possible side effects that I've circled. These are pretty common and will resolve within 5 to 7 days after you finish the dose. Okay.
Okay.
I'd like to make sure that I explained everything clearly to you. So can you please tell me, how are you going to take Paxlovid and what are you going to look for?
Okay, so each pill packet has 3 pills. I need to take 1 packet 2 times a day for 5 days and avoid taking my St. John's wort supplements and also any of the supplements that you circled on the list. And I can't remember what side effects to look out for again.
Right. So liver damage is the big thing.
Okay, that's right. So I'll call if I notice any changes with my eyes or my skin, my eyes turning yellow or my skin, or if I get real itchy or if my urine gets dark, I'll give you a call.
Perfect. We'll see you in a week for a reach.
Great.
So the most important things, and you know, she was able to teach it back. Of course, my patient Maya is very sophisticated. Great job. All right, I'll go one more thing and then we'll go on to culturally and linguistically appropriate services, which is kind of the meat and potatoes. I just wanted to bring up Small Steps to Health. This was actually a project that our residents did, primary care residents with Libraries Without Borders. We were able to do a health literacy intervention at a laundromat at 7 Mile and Van Dyke for several months before the pandemic. And we went every week and we did like a continuous quality cycle where every single week we met as a team and we talked about what we could do differently or better. And it was awesome. They got a chance to engage with community. They taught. We learned a lot about using props for teaching, demonstration, exactly all that stuff that we talked about. So over the pandemic, we weren't able to do that program, but we did come up with another one, and it's Small Steps to Health. And at the time, we're working in Narden Park because that's where our school-based health center is, Authority Health. Now I'm no longer with them, but that was the location. And basically, the whole point to Small Steps to Health is, you know, we had five different areas that we're talking about: high blood pressure, diabetes, nutrition, physical activity, and stress reduction. And it was, we made cards and posters and everything of just 3 to 5 small step behavior changes you could do to improve those conditions. And, you know, as physicians, Carrie, how many times do you go to the doctor and they're like, okay, well, maybe not for you, but okay, Ms. I don't know, CGW, we see that you've gained some weight over the last, you know, few months. I'm going to need you to walk 60 minutes a day, or, you know, I'm going to need you to change your diet completely, no salt, you know, cut salt out all the way, or whatever. We give big goals, and that's a turnoff, and it's impossible for humans to take all that in. Right. So what we do is we say, okay, if you're not able to walk, you know, 60 minutes a day, let's talk about what you can do. And maybe it's a 5-minute dance party with YouTube in your kitchen while you're cooking. You know, maybe it's something like that. If it's, you know, you need to increase water, you need to increase your water intake. That's always my favorite. Well, what if you just suggest, okay, every morning when you wake up, you're going to drink a glass of water. That might be something that someone can do. So I just quickly wanted to go through that as far as setting goals with patients, making sure that they're feasible, and that they're realistic, right? Same word.
Oh, that's very good. This is really good. Yeah, it did make me think about, so I guess I did teach back all the time. I would do summer camps every summer for like 20 something years. And in recent years with the active shooter incidents, so we would teach Alice, you know, we would tell the parents, you know, we put this in place. This is part of our programming. And so I would actually ask the kids, even down to the kindergartners, what does Alice mean? You know, and we would go over, you know, alert, countdown, all that, you know, what it meant, all the acronyms, what it meant. And then so they would understand it. So they knew, like, what happens if you are, you know, misplaced, or you get lost, or you leave the group. Well, you're not supposed to leave the group, but whatever. What are we going to do? What's in place? What's the protocol? And so, yeah, I see what you're saying. And I definitely ask the kids, what does that mean?
Mhm.
Did you understand what I said? And then you would have different kids explain it so they listen. And sometimes, what do? We learn from each other. Kids learn from each other. So yeah, that makes very good sense. So I guess I have been doing teach back. But you're right, and even with my kids as they got older, I do have a son who's a senior in college. As they got older with their doctor's appointments, they would kind of question some things. My son would say, "You're drawing my blood for what?" And so he would want to know what they were testing for, cholesterol and diabetes and what that means, and so yeah, because he kind of wanted to know. He let me know he was paying attention
Yeah.
to why, and then they would give you. I noticed that just on a side note. So when they were younger, there would be these long pamphlets and things about the flu shot. They got the flu shot and what it means. And now it's like smaller, it's one pamphlet. So they've taken some advice from experts like you all, like maybe patients don't understand. They can't read through 3 pages of what the flu is. They only need to see what it is, what it do, why you should have the, vaccine, blah, 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 and go from there. And so I will say it has been condensed over
Yes.
the years, just being a parent that took my kids every single year for their physicals and, appointments and things. I just made it a point to keep up with it, probably being a teacher and knowing my kids need to be in school because school is your job and, you can't go to school if you're sick. So, but yeah, okay.
Very
Well,
good.
thanks for hearing me.
Yeah,
Yes.
absolutely. That's all great. Great experience. Okay, I'm going to turn it back over to Maya.
Okay, thank you. So some health literacy strategy number 5, understanding or consider language and culture. So as we know, Wayne County is a huge mix of different language and cultural beliefs. Some of the pictures here are representative of some of the bigger populations in Wayne County. As we know, Wayne County does house the biggest population biggest concentration of Arab Americans in the entire nation. So it's important that we know who we're serving and understanding their language and their cultural beliefs. So let's begin with a review of class. So class standard, which means culturally and linguistically appropriate service. This is the framework to deliver healthcare services. It's respectful and responsive to the patient's cultural health beliefs, preferences, and communication needs. And class does promote health equity and reduces disparity. And that acronym again is CLASS. Okay, so some of the themes to class, let me just switch over on my side. I'm sorry. It's the principal standard, governance of leadership and workforce, communication and language, and engage continuous improvement and accountability.
I apologize.
It's okay. Okay, so strategies for implementing class. Assess the language preferences and language assistance needs. So sometimes this may mean as a community health worker or as the community liaison, again, understanding your population and having translated materials ready. In my experience, that does also help build rapport with the patients or with your population served because they understand, hey, Carrie's coming in and she took the time to translate this for us. Acceptable language assistance services and plan for interpreter services in advance. And I did mention providing the written materials in the preferred language. So culturally related strategies, respectfully ask the patient about their health beliefs and customs. So not assuming just because a person is from a certain area doesn't mean that they practice certain things one way or the other. Avoid stereotyping and acknowledge and address our own implicit bias because we have to be honest with ourselves. We all have those biases. So language translation services, do's and don'ts. So do use bilingual clinicians and staff members whose proficiency has been confirmed, staff who are trained as interpreters, on-site trained medical interpreters, and telephone or video medical interpreter services. Do not use clinicians or staff who have not been trained or certified as medical interpreters. A patient's family members, this does pose a problem with the patient's privacy. Respect their choices and have qualified interpreters present. I find that this is a big one because many patients, they're so used to having that family member that can translate for them. And minors should never be used. That is another very common one. Sometimes our population served who language is not their first, English is not their first language. They're minor children who may have been raised in the US and speak English very fluently. They do often use those individuals as translators.
Before we go on to the next slide, I just quickly wanted to add in, interestingly, I've been working with an organization on credentialing them for health plans, for payment. And every application asks, is there a staff member whose proficiency has been confirmed or, you know, have been trained as so they do actually make a distinction between someone who's been trained and certified, and not. And it's interesting because all places usually have that telephone line, interpretation line, but they don't want to know about that. This is a website from University of Michigan Care Guides. They have a really, I love her, Rudy Volk, I think her name is, who works on creating materials in plain language. So I just recommend checking out this site. They have information, either they've produced it or they've procured it from other sites. And everything is, the reading level is 5th to 6th grade. And they have translation in multiple languages. Some of the information they do have is not necessarily something you would use, like it's just a 1-page, all, you know, black and white. But it does have amazing information. So just a resource, that's all. Oh, and then this is just an example of MDHHS put out a bunch of different COVID vaccination flyers in different languages. So those are available.
I think I've seen the middle one. I have seen the middle one on the billboard.
Oh, I haven't seen any of these. That's cool. Okay, we're going to move on and talk about cultural competence. And so, you know, we know that religion, culture, beliefs, customs can influence how people process and understand health and how they make decisions related to their health. So really, cultural competence just relies on the principle of trust, respect for diversity, dignity, equity, fairness, social justice. And as providers, if we consider culture and language, we can better engage with patients in making treatment plans consistent with their values. So these are just some examples of how culture can impact health engagement. So for example, health beliefs. Some cultures, they believe that if you speak about a condition, it can happen. So you have to consider that. Health customs, some cultures, family members play an active role, like the elders in the family. Roles of women and men can, in society, can determine who makes the decisions, so ethnic customs. Religious beliefs, some religious faith and spiritual beliefs may affect how someone uses the healthcare system. We know that certain religious beliefs don't accept, you know, things like blood products. And then dietary customs. This is a huge thing. You know, we're always prescribing healthy food to our patients, but, you know, culture can really impact that if the dietary customs are different than what we as, you know, Americans expect. You might be prescribing a food that the patient doesn't know how to cook or isn't familiar with cooking. So demonstrating the cooking is important. And then interpersonal customs, some cultures, eye contact or physical touch will be expected, and others it will be inappropriate or offensive. So really getting to know the population you're serving as far as cultural and religious beliefs, and making sure, you know, that those are all considered and respected. Like Maya said, we all have implicit bias. It's part of our human, sorry, I just got a text, human defense mechanisms. And, you know, it is our job. We need to reflect on our bias. And there's a lot of work going on around this right now, or has been. Have you ever heard of toxic stress?
Toxic? No, I haven't.
You know what it is. How about adverse childhood experiences?
Yes, we've been trained on that, yes.
Okay, so this book, I'm going to say The Body Keeps the Score. If you haven't read it, I would definitely read it.
Oh, okay.
It's one of the best books I've ever read. I hate to be like that. And Bessel van der Kolk is still alive. He's around. He's like 90. He's like a Swedish psychiatrist or something. Anyway, but
wow.
But trauma, we know that toxic stress is any kind of stressful situation where your fight or flight goes up and it doesn't come back down. So for example, adverse childhood experiences, if you grow up in a household with domestic violence, let's say, the child's cortisol level, fight or flight, is constantly elevated, and down the line that can impact health, and it can impact behavioral health. So we really do understand how trauma and toxic stress impacts the body and mind. And I do a lecture on trauma-informed service. And again, this could take weeks and weeks to go through all of this, but I just encourage you to read the book. Maslow's hierarchy of needs, this falls into it as well. Maya, I don't know if you want to share, but actually, Maya, why don't you go ahead and share?
Okay. So I'm sure we've all seen this before. I love this pyramid. I love to show this even to our population served. It's difficult to explain self-actualization to a community member when they have an eviction. So if we think about the push that we've had especially post-COVID, for mental health services. But we cannot downplay, or we can't excuse that there are people who may be going through domestic violence. So yes, we want our patients to be, have high self-esteem and feel great about themselves and practice self-care. But that goes out the window if I have to go home to no food, or I can't really process a COVID screening or the need for a COVID vaccine if I don't know how I'm going to feed my children, or who's going to watch them while I'm at work tonight. So all these things go into the hierarchy of needs. So we have to address the basic needs, food, shelter, safety, before we can address some of I like to say the higher things on the pyramid, love and belonging and sense of community, because those things go out the window if our basic needs are not met. Does that make sense? I hope that
does. It does.
Okay.
Yeah, that's true.
That was great. That was great.
I remember learning that.
This, I don't know if you've ever seen, but this is an image called the Pair of Aces. This comes out of George Washington University, our buddy, Dr. Dietz. So adverse childhood experiences, we've identified, we understand that, and we're working so hard to try to mitigate this now and prevent ACEs and all this stuff. But at the same time, we have to consider the adverse community environment and all the inequities and what we talked about previously. So it's definitely a challenge, not only creating or preventing adverse child experiences, but really building up and building capacity in our neighborhoods and our communities. So at the end of my trauma-informed service lecture, we go through some questions. And so I just listed these so you can think about them. And I will send the slides after too, Carrie. So, when you're working with a community member, have you considered the trauma or culture or language that this person experienced? Creating a safe space, a safe environment, that's so important. So are you creating that? Do you have any unconscious or conscious bias to consider? Can you even be unbiased? Some people, I'm not going to go into that. How does your background, history, et cetera, impact your ability to serve, right? So just self-reflection and understanding how are your actions making others uncomfortable? Are the words you're using respectfully and culturally important? And are you actively listening, or are you just talking? So these are the things that I ask my students to think about when they're getting ready to go serve a population. All right. We can take a 10-minute break, or this is the only picture that I literally stole from Google and didn't care. Like, you can see the plot. I was like, this is so cute. I don't care. I'm taking this. Carrie, would you like to take a few-minute break just to stretch, and then we'll come back?
I'll take a few minutes. Yes, I'm gonna go use the bathroom. Thank you so much.
We'll see you in a few.
Okay.
the neighbor is getting their entire, I don't know what they're doing. They're replacing the driveway or something. And so it's been really frustrating. I keep hearing construction noise. I'm like, mute, mute, mute.
Okay.
So that's
Feel
what
like you
I'm
have
trying to avoid.
neighborhood.
All right. All right, welcome back.
Well, thank you. That's very good. Lori says hello.
Hi, Lori.
She's on the call. She's nearby, but she's on the. She may come by again.
Okay, I'm gonna have to edit and post and take this pause out. I just realized the recording. Okay. So, okay, now we're gonna move on to some strategies. There's two that we're gonna review. Before we get started with that, let's just do a quick overview of vaccine hesitancy. According to the World Health Organization, it's defined as a delay in acceptance or refusal, despite being available, and it is one of the top threats to global health. So the causes of vaccine hesitancy are pretty much the same that we've been kind of going through. Systems set up, the way systems are set up can really impact that, right? So healthcare and socioeconomic inequalities and inequities, lack of effective public health messaging. Like we said before, this is very important. History of unethical research with different populations has caused, mistrust, which makes sense. Unfortunately, that leads to lack of acceptance. Social determinants, we've talked about that. Misinformation, disinformation, conspiracy theories, this is a big one. And then again, the more social determinant of health related stuff like access. And definitely with COVID in the beginning, it was like so crazy. You could only unthaw it if you had 10 patients signed. There's all these rules about thawing it and how long you can keep it, and yikes. So this is the Omicron bivalent. The original vaccine series, I'm sure you're aware, was covering the original strain, so mono. And depending on whether you got Pfizer, Moderna, Novavax, or Janssen, you got 1 to 3 doses.
Yeah. Mm-hmm.
The booster is, bivalent. Of course, it covers 2 strains, and it's recommended for everyone. So that's what our campaign is really going to push. Mm-hmm. So we'll go through motivational interviewing, and then we'll talk about combating misinformation. I think we're doing pretty good on time too. Oh, muted. You're muted.
Oh, sorry. We'll be skilled lip readers by the end of this.
Right.
Anytime.
Motivational interviewing. So are you familiar, Carrie, with motivational interviewing?
No.
Okay,
I thought
great.
I've seen it all in the world of education, but no.
So I'm sure this is something that you've been doing all your life as well. So motivational interviewing is the guiding style of communication which balances good listening with giving advice. So it's designed to increase patient motivation and the likelihood of health behavioral uptake. And it's based on respectful and the curious way of being with people that facilitate a natural process of change and respects the patient's autonomy. All right. So the spirit of motivational interviewing, I think this is a great table. I'm sorry. I hope I'm not taking this over. Is this your slide, Carrie? I'm sorry, Carol.
Nope.
Dr. Custer. Okay.
Yeah.
Okay. So motivational interviewing essentially is looking at what the patient or the consumer wants. So it's if I want to give an example of this, because I know this is kind of a lot of information. It's more of the last part of the table says honoring a patient's autonomy. Although the practitioner informs and advises their patients, they acknowledge the patient's right of freedom to not change. And basically, it's up to the patient. So instead of saying this is what you need to do, it's listening to what the patient wants. So if the patient is saying it's important for me to live a long, healthy life and be here for my grandchildren, instead of saying, well, you need to take this medication or you're not going to survive, it's putting the onus back on what the patient wants. So I hear that you say that you want to be here for your grandkids. So by taking this medication and staying healthy, this is one way to ensure that you do that. Does that make sense?
It makes sense. Yeah. Mhm.
Yes, we're trying to get away from the authoritative, paternalistic hierarchy, patriarch.
Yes. Yes. I think about how what some things the doctors have said is in my years, I'm like 53. And yeah, I remember I had a really bad, have you ever heard of pharyngitis on a side note? I didn't even know what it was, so I got it, and it was like, "That's bad. You have," the way you were talking to me, I said, "Oh my God," I thought I was gonna die. And you need to take this, and where were you? And I figure I probably got it in one of the schools teaching. I don't know, but it was the way he explained the illness and what it was, and how I needed to stay home for a couple of days, and I don't know, but yeah, I could imagine what that would be like to someone who's already, probably scared because I don't like doctors.
Absolutely.
Yeah.
It's very off-putting. I can think
Mhm.
of my pastor growing up. He would always say, I hate going to the doctor because they never have good news. So
Oh,
it's like
that's true. Yeah,
it's like
that's
one of
true.
those. So imagine if you go for our patients, our population served that are going in with that attitude, and then they get that pushback. It is very off-putting. It's like, well, I don't want to. Then you get those attitudes where it's, I'm not going to the doctor. They're not going to tell me
Right.
anything good.
Been good.
So
Right.
Correct. That's true. Very good. Yeah.
yeah. So the next slide, it talks about ORs. So what ORs are open-ended questions. So instead of yes or no, okay, well, tell me why this is important to you, those sort of questions. So it pulls in more information out rather than are, do, did, could. And then affirmations. So it's recognizing and enforcing success and enabling the client to see progress. And reflections. I feel like I always go out of order with this. Okay, so mirror what the client is saying. So examples, sounds like to me you are saying, or it seems that, those phrases, and then summarize. So client can hear stated motivations and ambivalence, enable the clients to clarify poorly communicated information.
And Carrie, I will say this is just like Teach Back. There's a lot of YouTube videos you could watch, but this is something you have to practice. You can't just pull this out. You have to actually think about what you're doing. So it takes some time.
Yeah, so this just gives some more breakdown. So motivational interviewing strategies start with open-ended questions. A soft start to a controversial topic enables engagement. So some of those tough conversations, unfortunately, they're tough conversations. But if we start with the open-ended questions, it kind of softens it up a little bit. Acknowledge the patient's concerns without judging. Empathy reduces the perception that you are approving or disapproving with someone. Empathy goes a long way. So I learned that from my years of customer service. People just want to be heard. Whether we agree or not, that empathy is huge with building rapport. So even if you don't necessarily agree, that empathetic ear is huge. So avoid criticizing the patient's information source. This is a big one. I definitely see this during the pandemic. Our elders, especially in some of our communities of color, our elders are everything. My grandmother was everything. So my daughter was born with like a funny belly button. My grandmother told me, put a silver dollar on it. I went to the doctor with a silver dollar taped in my daughter's diaper, and my doctor was like, what is going on here? So it's like, well, my grandmother said that because my grandmother, she's the elder. So she's been here, all this time. And what she says was so very important. So criticizing sometimes criticizing what's an elder or information that a patient may have spent a lot of time researching, that's the breakdown in trust between you and the patient. So not criticizing, instead of arguing the misinformation, just provide the correct information in a positive way. So show awareness of your status as a messenger, especially of people of color. Who we are as a messenger matters. So whether I didn't always understand this as a CHW, but I was very relatable, being a single mom, a woman of color. So a lot of the patients, they relied on the information that I gave. So I had to be aware of that. So link vaccine acceptance to the patient's hopes and goals. So it's important for me, I'm a caretaker. So I was really hesitant on getting the vaccine, but as a caretaker, it did make sense when my doctor, my provider put it together, hey, you don't want to pass anything on to your mom. So linking it again, that listening and understanding what's important to the patient and linking that to their goals is very helpful. Okay.
All right, we're going to do an example. Any questions, Carrie, or comments?
No, that's very good about the empathy portion of it. And so it goes back to, I think, in the survey I took prior to starting, just about like if you put the practices in place anyway. And so it's always like inclusion and taking, I guess, which is interesting, just the account of all the cultural, advantages and disadvantages that, that we're dealing with. And so I will say my kids always having attended a school which is a diverse population and culture, they like have a really great acceptance of that. I can say that.
That's awesome.
I really do. I think my daughter embraces it even to the point where I remember there was this Asian dish and she's like, we had to go to these different stores to find it. And it was hard. We were like in Clausen, I'm like, where do we have to go so we can make this dish that she learned in school? So, sometimes it's a good thing, and then just like attending a school like that, like there's a huge heavy of the Latino population, Southwest Detroit. And, my son used to play football over there and just learning about all of that. And then he did have these big powwows with the practices. And so his thing wasn't always to bring, what was it, the big spaghetti dish. He's like, no, Mom, we got to bring a Mexican dish. I'm like, since when? So, it's just that acceptance. I mean, but I guess with the patients that you're going to deal with and that as the CHWs go out and with the reporting, this is just so critical. I'm just excited about that.
Great.
All right, so Maya and I will do another example quickly. We're going to do I'll be the healthcare provider and Maya will be the mother. And first, we're going to do a traditional approach, Carrie. So this is the way, that we've been approaching. And then we'll do a motivational interviewing approach. All right. It's important to immunize your child. If not, you're putting him in danger. Do you know there's still cases of measles in Canada? I should change it to US. This disease could be very dangerous. And what about meningitis? It could be fatal, You should update your child's vaccinations as he's already late according to schedule. We could do that now if you want.
I don't see the urgency, and autism is worse than measles. There are more problems and solutions in this vaccine. Moreover, it's completely unbelievable to give so many vaccines at the same time.
Studies have demonstrated that there is no link between autism and measles vaccine. The vaccine is safe, I assure you. You should be aware of the information you could find on the internet. Giving several vaccines at the same time is safe and is not associated with more pain. We should update his vaccines now.
Well, I heard something else, and not only from the internet, I do read a lot. And vaccinations are not mandatory, and I can do whatever I want.
Yes, you're right. It's not mandatory, but you're putting him and other children who cannot receive vaccines in danger. The risk of diseases are much higher than the risk of vaccines. If I'm taking this time to speak with you, it's because it's really important.
Well, that's easy for you. Everything is quick. But what if he gets autism? I'm worried about the risk of vaccines, but you don't seem to be worried about the true health of my child.
Of course I am. And I'm worried about the fact that he could get diseases that could be prevented by vaccines.
I don't think that we understand each other. So let's just talk about this at a different time.
Okay, so I adopted the role of the expert. I used a directive intervention approach based on argumentation, right? Argumenting and writing reflex. So this led to an opposition. So now we're going to do another approach using motivational interviewing. So, Ms. Campbell, what do you think about the advantages of vaccination?
Well, I know that vaccines protect children against several diseases that we don't see anymore. My child received all his first vaccines, but I'm worried that the measles vaccine could cause autism. For other vaccines, I have fewer doubts, but I'm still hesitating.
As you said, vaccines have reduced diseases in such an important way that they are now much less frequent. It's why you vaccinated your child when he was a baby. If I understood you correctly, with the exception of measles vaccine, other vaccines seem safe to you.
Yes, I know it's a good thing to prevent those infections, but about measles, I'm conflicted. I've read a lot of books and articles. Lots of people are worried about the link between measles vaccine and autism.
So you find that it's important to protect your child against diseases when the vaccines are safe, but you're worried about what you've heard regarding autism and measles. I see that you've done a lot of research about the subject. If you agree, I could give you some additional information for studies on autism and measles.
Oh, sure. I want to know exactly what's happening.
In fact, you're right. One study had hypothesized a link between vaccine and autism, but the study was fake and the author lost his medical license. More than 500 additional studies around the world have been done and demonstrated there's no link between the vaccine and autism. The frequency of autism is the same in a group of vaccinated children as in non-vaccinated children. What do you think?
Well, I'm not so crazy. So you're saying I'm not so crazy to be worried about that?
Of course not. You're totally right.
Okay, well, thank you. Thank you for taking the time to understand my concerns. I'll think about it a little bit clearer now.
Okay, so in this case, MI allowed the mother in a non-judgmental way to express her ambivalence, her concerns. So, the interaction between us allowed me to give her some solicited information that she accepted. So it's about framing, it's about open-ended questions at the beginning, it's about active listening, reflecting what the patient or person says, and then really summarizing it in a way that, their stated motivations are the reason why you're doing something. Any questions, or does that make sense?
It makes sense. Yes, I could see the difference. It makes sense.
Okay, great.
Yeah, empathy.
Just thinking and actively listening. Just thinking. So misinformation and disinformation, we're going to move on to that. I'm sure you're aware of the role of social media and online platforms as far as, and misinformation is stuff that is error and mistake. I always say misinformation is mistake. It was an accident, right? Or it's not willfully incorrect. Disinformation is the stuff that people are putting out that's incorrect and not true and causing a lot of the issues that we see with our vaccine hesitancy. So we'll talk about social media real quick, and then we'll talk about the importance of trusted messengers, which Maya has already touched on. So this slide, Carrie, is just an example of the social media landscape in 2022. The whole purpose of this slide is just to show you that there's a bunch of different sources. I mean, there's no way all of these sources are the same, right? So there's a lot of variation in where people get information. Therefore, there's a lot of variation in the information they're getting. So again, we recommend just disseminating factual, easy to understand information to combat. It's better to provide factual information than argue. You don't want to judge, you don't want to argue. And then using trusted messengers, we talked about briefly, but your CHWs can be your trusted messengers. You could also, have a celebrity or a community champion or a faith-based person who's well-respected in the community, or your influencers. This is just the information as of a week ago. This may or may not works, but for some people it may work. The information is, if you've been vaccinated, you are much, much less likely to be hospitalized at the end of the day. and to die. And actually, when you're again, not everyone cares about the numbers, but if you have the Omicron booster, you can see that your chance of death from COVID is basically 0%. So these are important things to be able to share. Like I said before, does this change someone's mind in that age group, 18 to 49? It may or may not, but it's definitely good to have the right facts when you're talking. All right, so we turned this into a discussion. Have you had any experiences with vaccine misinformation or disinformation?
Oh, yes. So prior to my employment here, I worked for a company where, we provided, like I said, latchkey services for over 20 something DPS schools, in the last few years, but during COVID and prior to COVID, we were at 8. But a lot of the staff were very hesitant about the vaccine because they thought that it would cause, in some cases, death, or that they would it would not really fully protect them, or that it was created too fast, all those different things. And then even parents were, saying things about the study you brought up in the last slide about, the link between, if you get the vaccine or any vaccine is going to cause autism. And that's, of course, that's not how it works. And then actually, I had to remind some of my staff, the seasoned staff, have been with me for years. We've had studies, where we've actually had U of M or Wayne State come out, and there isn't a link between that. Just like we've seen studies where, like with autism, it affects like a huge population of Caucasian students and kids versus African American, just like more African American students have asthma and why asthma affects them, and then you go to the effects of what the parents were doing while they were pregnant with the child, and what does the community look like, lead in the house, things like that, smoking, whatever. So I said, so we sort of have to look at what the information says and how we use it. So just as a parent, I believe in just reading some of everything. And I remember my son, he was a junior in high school, and I think the principal sent home twice kids who were coming down whooping cough. And so I'm like, who still gets whooping cough? But they were telling you, make sure you're updating your vaccines and check your child. And if they have these symptoms, and I was like, who still gets that? And even my daughter, when she was in 6th grade, someone in her class got the mumps.
Wow.
I'm like, wow, and measles. So they send the information out. Parents were upset. There was a parent meeting, things like that. But I guess it's just a matter of just sharing, with my kids being in college, I tell them read multiple sources, vet things properly, look and see what's credible, what's not, and compare and go from there. And I guess moving forward with this work we're going to do on this grant, and how we impact the community and how we, dispel all these health issues, I guess you do a good job with, information. I did have a question about the information for parents to read and, the community and especially our senior population about how they feel with the second and third, like boosters, are they hesitant? And how do you get past, oh, here comes another shot? And, looking at the numbers, the deaths are down, and so they think that why would I need to get it since the deaths are down? But what scares me is that people are still dying every day with COVID. Every day they're still, even across the world. And,
Yeah.
so those are just my 2 cents.
Well, the pandemic is not over, unfortunately.
No, it's not. No, it's not.
Yeah.
No, but we're up to date to make sure my kids are up to date. And actually, my daughter, she's at Clark Atlanta in Georgia, and she couldn't even step foot on campus without the booster. And still, even so, we took her back last week, and she had to have a negative PCR. They're
Wow.
still requiring that. So,
Yeah.
not just a home test, like we all had to be tested, like just to step foot on campus. So they're very, whereas my son who's at MSU, I'm like, do you have to have a test when you go back on campus? He's like, no, mom, but, I mean, they still told you in an email, hey, make sure you're child gets the flu shot, that was communicated from MSU, and, you know, make sure they kind of stay up to, you know, date. And then in some of his classes, he still has to wear a mask.
Mm.
Depends on the professor, but, you know, so I just look at those things and just, there's just a difference there. But, you know, maybe because Clark's a smaller campus, I'm not sure.
Yeah, yeah, that part, who knows, but
Mhm.
interesting.
Yes, but this
Yeah,
is
very-
actually very good. Yeah. And how you communicate. It's just funny how it's just so different now. We were just told to do one thing, you just did it, you know, and you can't talk to the different communities that way. You can't communicate in that space like that anymore.
No, and it's definitely a generational thing too. I mean,
Yes,
boomers,
yes, it
boomers
is.
accepted authority. My
I
generation,
think that,
Gen X, we started to
yes,
question
me,
it.
see,
Millennials,
I know my ass is young.
and then
Yeah,
Gen Z. Oh, I
we
have
just,
two Gen Zs.
I,
They don't care about anything. They do, but you know,
right. Well,
It's
I say your generation is gonna have to fix the world.
yeah.
You have to fix the planet.
Well,
I'm a true millennial, you know, so we had the pleasure of seeing both sides,
yeah.
the information and but yeah, my daughter's a Gen Z, and if it's not in a short TikTok video, it's like, Mom, this is too much, and they question everything, which I love.
Yes.
But
Right.
yeah,
Yeah.
Yes.
this is
But
good.
and
Thank
I
you.
was gonna say on the side note, my mother, because my parents are deceased, but my mother-in-law would, you know, one thing we would do when the kids got a little cough or a little cold, we would put the Vicks on their chest and put a paper bag so they could sweat it out. That worked. That did work.
That did
One
work.
time we told the doctor, they're like, "You did what?" We told Chloe's doctor that, and they're like, "Yeah, you know, it kind of worked, you know." I mean, because we didn't believe in taking a whole lot of medications. Everyone's not going to take NyQuil and all that and Sudafed, but sometimes just, you know, a little burners, a little
Yep.
warm burners and that Vicks on the chest will do it.
You know, for
Fix
us
and burners.
Michiganders, Berners is like totally medication, and Berners is
Yeah,
like the cure for everything. So
yeah,
yeah.
it is very right.
Oh, that's funny. Okay, we're gonna skip the case. But the case was basically Eliza is long haul COVID and she just nods through the appointment and she doesn't understand. So we're gonna skip that today. Because we have to have you do the post within our 10-minute time frame. So Maya, I'm gonna let you take it away. And you're muted.
Yes. So some of the key takeaways that we hope you got today. Well, first of all, Carrie, great conversation, great perspective, different perspectives. So I loved working with you today. So the key takeaways, low health literacy is associated with lower health knowledge, poor medication adherence, increase to ERs. ERs is the use of primary care, and increased mortality rates. All these things impact our quality of life. It is important to use, as you mentioned, those universal precautions. Don't assume that a patient has low literacy, or please assume that everyone has low literacy levels, just like we do with communicable diseases through bloodborne pathogens. Assume everyone has low literacy. Improving individual and community health literacy levels can reduce vaccine hesitancy and increase COVID-19 vaccination rates. So in final, the recommended grade level for all written material, as we discussed, is 5th to 6th grade. Health literacy strategies can be used to increase the patient's understanding about their health condition and empowers them to take an active role in their health. Clear communication, teach back, using linguistically and culturally appropriate materials, motivational interviewing, and combating misinformation.
Okay, this is our contact, I should say. I forgot why we added you. So if you need to get a hold of us, of course, you don't really need this because you have Lori right next to you and she knows.
Yes. I was gonna say that this has just been very good. I'm so happy that I had the training and everything. But I was gonna say was a question about the misinformation. So the communication that comes out in the literature from NDHHS has it been communicated to them that, you know, how they put the literature out, what the reading level is. Because like I said, you know, I've always told my kids, you know, the free press is written on a 5th grade level, and so they would be hesitant, like the newspaper. I can't read the newspaper. Yes, you can.
Mhm.
So they could feel more comfortable about it. Although I do wonder about when I taught 3rd and 4th grade for many years. If Harry Potter was ever on it, because I had kids who were reading like Harry Potter
Yeah,
in like the 3rd and 4th grade. I don't know if that's written on the 5th grade level, but they were reading chapter books. The kids thought they grew up when they got a real report card. They started reading chapter books.
yeah.
But that's great. That makes sense. Easy breezy is what I say.
I'm gonna look up the reading level while you do the post. Just an FYI, there is a available training on this is through the CDC, so you could take a look
Okay.
at that. And
Oh,
these are
great.
the resources that we pulled from for our lecture today.
And I can't wait to get the slide. Okay, I did take note.
And then
That's great.
actually, if you want to use the link in the chat, we can go ahead